Okay. Thank you so much for attending this session this morning. And as Kim alluded to, we're talking today about moving towards slideless hematology practice. Disclosure, lodging costs and honorariums paid by Sysmex. And before, I wanted to give a little bit of background about our practice here at Children's. And so by far the largest consumer of hematology testing at Children's is the Center for Cancer and Blood Disorder. It consists of two locations, one on the main campus and one on our smaller hospital, which is located about 24 miles away. The main campus has one clinic on the 6th floor, which is in the same tower as the lab. The second clinic is on our smaller hospital, which is a 72-bed hospital in Plano. The clinic sees about 21,000 annual visits per year and about 85 patients per day. These visits generate about, on average, 40 manual differentials per day. The inpatient unit usually has an average of 30 to 40 patients, of which 25 are oncology patients and 10 are hematology thrombosis patients. The center is staffed by 25 attending physicians, 11 fellows, and 175 ancillary staff. And on any given day, there is usually one fellow and two to three faculty taking call for both campuses. And so they have to cover both our main campus and also the ancillary, the smaller hospital. So this rather convoluted diagram shows the workflow for the CCBD as it relates to the lab. And so when the patient arrives, blood is drawn by a phlebotomist. It is then tubed to the lab where the specimen is accessioned. Peripheral blood smear is made, off of which the peripheral manual differential is performed. An extra peripheral blood slide is actually made and sent back up to the clinic so that the clinician can view the slide prior to seeing the patient. And then the specimen is then placed on the hematology analyzer so that the automated CBC can be made, and then the medical technologist performs the differential count, at which time the clinician finally sees the patient, waits for the results, and then discharges the patient. So even though this is a rather convoluted workflow, there are only 3 steps that are of value to the clinician. The first step is the patient arrives in the clinic, the clinician sees the patient, and then the visit is concluded and the patient is discharged. Other than that, they really do not care about the rest, but unfortunately we do. The other part about this is that this is obviously rife with opportunities for error and delay. Number one, often the clinicians forget to order the extra slide, and so they spend a lot of time waiting for something that will never arrive. Number two, the clinician depends on the phlebotomist to deliver these extra slides to them. Oftentimes, the phlebotomists, unfortunately, are busy drawing patients and forget and do not deliver to them in a timely manner. And number three, it has to be tubed up by pneumatic tube, and very often they break. And so you have an oily mess in the tube station. So one of the surprises that greeted me when I came to Children's for the first time is that they told me that the laboratory had agreed to set up a satellite lab up on the 6th floor in the CCBD clinic space. The CCBD had received a large grant, and they would be able to renovate the entire 6th floor. And part of this would be to consolidate inpatient and outpatient activities on a single floor. And so what they wanted was to include a satellite laboratory that would hopefully increase their workflow. So I calculated that the cost of this would be about $400,000 initial cost, and then about $134,000 each year. And all this expense would go towards performing 40 manual differentials a day. Some of the benefits of establishing the satellite lab is that it would bring the program into parity with other pediatric hematology oncology programs of similar size. They had done their research and done site visits to Children's Healthcare of Atlanta, which also had a satellite lab in their clinic space. it would presumably decrease transport time for the specimens, which is true. We did time studies and determined that it often took 7 to 14 minutes to tube the specimen from the clinic down to the lab. There would be possible increase in communication with the lab tech. Of course, this is kind of a double-edged sword because you know that there will be different clinicians and they all have different priorities, and they're all going to be talking to the lab tech at once. And so it's very difficult to say that this will improve workflow due to the fact that the lab tech is going to be pulled in different directions. The last point is a decrease in travel time to view the peripheral blood smears. This is also true because the clinician would only have to walk out through the hall next door and to view the slides. The disadvantage, however, is that there would be a possible increase in turnaround time for the CBCs with manual differentials. This is not intuitive at first, but if you think about it, the workflow in our main lab is that there are at least 4 med techs performing manual differentials at any given time during clinic hours. We are able to ramp this up during times of heavy volume by recruiting techs from other parts of the lab. And so therefore, we can go up to 8 if needed to work the backlog of cases. However, with the satellite lab, there would only be 1 lab tech manning the satellite lab, and there would be no question of sending additional techs upstairs. Also, I could not guarantee that we would have a slide scanner, and so the manual differentials were likely to be performed on the microscope. There would be less space and resources to allocate for other CCBD projects, and lastly, the long-term operations and resource management issues were hard to justify for just 40 manual differentials a day. So I invited the clinician leaders to come to the lab and to meet and discuss the project, and also to give them a tour. And so one thing that we looked at was the television, and this was kind of an aha moment for the clinicians and for us because they had never seen the television instrument before. For those of you who are not familiar, it is a slide scanner with associated software that allows for, with an internal microscope that takes individual pictures of the slides, of the cells, and then pre-classifies them using artificial intelligence. It can pre-classify 18 classes of cells and is actually pretty good. It gets it right about 80% of the time. And so the techs then review the differential and then verify it. And so they have to reclassify about 20% of the time. It uses barcoding technology, remote viewing software, and a database of archives. So the compromise that we came up with is that I would give them access to television. And so at this time, the remote viewer software had to be installed on individual computers. And there was a key, which is what we call a USB dongle. And once you had that, you were able to view the cells on the computer. So we installed television on the computer upstairs in the clinic space. And the clinicians absolutely loved it. They no longer had to wait for slides. They could see the cells at the same time as the techs and be able to more efficiently see the patients and discharge them. For those of you who are not familiar, again, these are the individual images of the cells. I call them glamour shots because no matter how bad you're staining, they manage to make it look good. Again, the differential has to be verified by the tech, and most of the time they have to reclassify the cells about 20% of the time. So after this initial success, they agreed to not have the satellite lab anymore. And so we did away with that. And we thought, this is an opportunity to expand our cooperation. And so the Television project was born. This was a partnership agreement between Children's Hospital, Sysmex, and Television. We were the initial site in North America to test the Citrix-based television remote viewing software. Prior to this, like I said, you actually had to install the software onto individual computers and use the dongle as a key. After this, anybody with access to Citrix could then view these remote viewing software from home. We agreed to purchase additional slide scanner for our legacy or smaller campus. and 7 additional software viewing licenses. These are the dongle-based ones. And we also purchased a virtual server for storage of images. This is a visual schematic of the project. So we had one slide scanner already. We purchased a different one. The remote viewer software now allowed us to view the images from anywhere. This allowed for a lot of flexibility in staffing. Anybody who's managed personnel know that oftentimes people call in because they have to stay home because the piping broke and they have to wait for the plumber. Now we can actually have them, as long as they have adequate resolution from home, they could perform the manual differentials from home. Also, our hematology supervisor very often would log on from his office and perform the diffs if there was a high volume at the time. This also led to standardization of care across campuses because prior to this, all the manual differentials at Legacy were performed on the microscope, and now they also had a slide scanner. And the cost of the project was less than half of what the satellite lab would have cost. And so the initial cost was close to $200,000 with only $18,000 in recurring costs. So another benefit of this project was that the clinicians could actually view the images from either campus. This is very helpful because, as I said before, there was one fellow and 2 to 3 faculty taking call for both campuses. And so now, instead of having to drive up the 24 miles up the toll road to Legacy, they could just view it from home or from the Dallas campus and be able to initiate the care for the patients from our Legacy campus. This is a graph showing this is an unexpected finding from when we instituted the television at our smaller hospital. This is pre-implementation, and so what I want you to note is the volume and also the percent defect. And so these 11.3% of the manual differentials took longer than our 60 minutes, which is our goal. And so, and on average, each manual differential took about 37 minutes. After implementation, the mean is still about 34 minutes, so half an hour. However, the percent defect had dropped by half, and our number had increased by over half. To make sure this was not a fluke, we looked at additional 2 months. Winter is usually our heaviest season, and so the number had increased yet again. The defect rate had remained the same, and the mean had remained the same. The reason for this is that the television kind of serves as extra tech, because once you load it on there, it's doing its thing. It's taking pictures of the different slides and classifying it for you, and it just waits for you to come back and verify everything. And so even though it doesn't really even though it doesn't decrease the time it takes, it definitely allows you to have more productivity. And so the next step in the project was to be able to do a single work queue. So now I have the techs from both campuses working off of a single work queue. It doesn't matter if they're on Dallas or a Legacy, they're working off of one work queue. The reason I did this is because of the fact that because this Legacy campus is so much smaller, we oftentimes have a skeleton crew. And so you can imagine in the middle of the night when you only have 2 lab techs, if anything blood bank related comes in, they're dead. And so what this allows us to do is to have more flexibility so that the Dallas campus can help them at night when they're their staffing is low, and they can help the Dallas campus during the day when they're slow. Now I want to kind of explore the clinician experience of having access to television. So these are real cases. The first frontline example is that a preschool-age boy just adopted from Uganda presents with fever and possible jaundice. He had previously had to spend 2 months in Uganda when he got IV antibiotics for malaria. Since he's new to our institution, there's no medical record, no known prior history. This, of course, occurred on Thanksgiving. Always happens. And the rest of the children are crying because the youngest, because she thinks this means her parents are going to have another 2 months in the hospital there. The pediatrician on call calls our attending infectious disease consultant and says, what would it take for us to be able to send the patient home with the family on Thanksgiving safely? So the ID doc stopped by the lab. We showed them the images from the television, and he determined that this was a low parasitemia load, and so this is less likely to be falciparum and was rather ovale. And so they treated with chloroquine and sent the family home with a house call on Thanksgiving. Example number 2 is that another preschool-age boy transferred from a hospital in East Texas with fever and vague complaints. They were transferred to the inpatient medicine service and for further workup, and they noted some asymmetric in the one leg and was warmer than the other. The resident on service called the lab and to discuss the manual review of the CBC to determine what was wrong with his patient. We saw blasts, and so immediately they were able to shift from diagnosis to acute treatment, and the images were reviewed by the hematology fellow on call, and they would initiate the treatment and told the family that they should not go home drive home back to East Texas yet. So future digital morphology aspirations. It's a very good product, but I think there are things that can be improved on the product. Number 1, we would like to be able to have the images available through the electronic health record. That's not possible yet, but that's definitely a future aspiration. We would like to make it entirely slideless hematopathologist review. Right now, they get the slide and they see it from television, but in the future, we would like to speed this up by only having the television images. And number 3, there are some limitations in terms of being able to view the feathered edge for platelet clumps and and large platelets. And so this is still an issue with some of our hematology patients that the clinicians still need the slide in order to assess for platelets. So in conclusion, the connectivity has allowed for increased productivity and flexibility in staffing. And also it has allowed for better patient care by allowing the clinicians rapid access to the images and so that they can begin the diagnosis and treatment of patients. Thank you for your time.
Thank you so much.